Hello, friends. Welcome to the Forward Think Tank podcast, a place for sharing stories of hope, inspiration, and wisdom on all things holistic health. I'm your host, Jamie Mazza, a holistic health coach and lifelong dancer. After being diagnosed with a rare thymic tumor and autoimmune disease, I am on a mission to fully, radically heal. Tune in as I share stories from my personal healing journey, interviews with forward thinkers and healers in the wellness industry, and stories from incredible humans who have gone through their own health challenges and continue to move forward in hope. Thanks for tuning in. So grateful you're here. All right. Hello, everyone, and welcome back to the Forward Think Tank. I am here today with a very special guest. I know I put a little preview out there, and some of you were very excited to hear this conversation. I am very happy to have this conversation, and I am very grateful. And if you're wondering why I'm wearing my sunglasses today, it's because it's not an easy day for me. I'm having a little bit of an autoimmune flare with my ocular myasthenia gravis. And so when that happens, unfortunately, sometimes I need to close one eye. So it's not a lot of fun, but I didn't want to delay this conversation. So I have here with me today my oncologist, Dr. Saxena. Thank you so much for being here. Take a moment to introduce yourself if you don't.
Thank you. Thank you so much for having me and inviting me. My name is Ashish Saxena. I'm a medical oncologist, and I specialize in lung cancer and other cancers of the thorax, including thymomas and mesotheliomas.
Nice. And you're at New York Presbyterian. I have had, honestly, an incredible experience with you and so many of the nurses on the floor. My surgeon is there as well. And I know you and Dr. Port have a great relationship. He actually had told me when I initially got booked with another oncologist coming out of the hospital last year, he's like, no. I need you to talk to Dr. Saxena, make an appointment with him now. I think he worked me in there somehow in some way. And I just want to thank you for all your support. I know that I can kind of come at you guns blazing some weeks, try to make it funny, more so to make myself feel comfortable, because this is, a very heavy and serious conversation. But I appreciate how just kind you've been to me, and you take my jokes and you laugh at them, and then we have serious conversations when we need to. So, thank you again for being here and doing this with me.
Absolutely. You make it fun. So even coming in. So, we look forward to it.
Intended.
No fun.
So tell me, I'm actually not sure with this question, what inspired you to get into oncology, and how long have you been doing this?
Sure. So I actually, my mother had lung cancer. She was young and was never a smoker. And so she, this was quite a while ago. This is like 2003. So lots obviously changed by then, but she passed away pretty quickly. And that sort of inspired me to go into oncology in general, and lung cancer specifically, which also generally includes a lot of the other cancers that happen in the chest, like thymomas.
Wow. I did not know that, and I'm so sorry.
Thank you.
I think no matter how much time has passed, that doesn't get easier. You probably, maybe not off the top of your head, but might know from my medical history that my mother's mother, so my grandma, also passed away from lung cancer. I was 15 at the time. She was 64.
Yeah.
Was a smoker. Yeah. A lot of my family members on that side were also prone to lung cancer as well, but a history of smoking. But yeah, it's crazy. I don't know if you're seeing that at all. It's becoming more and more common from what I'm hearing, because I'm connecting with other people going through different types of cancer diagnoses, going through all this myself. A lot of younger people I'm getting to know who are getting diagnosed without being smokers either.
Yeah, it's actually a big group. And, part of it is less people are smoking. So before, everybody was a smoker. You saw the lung cancers a lot in that, but now we have a large group of patients that are never smokers. They do tend to be younger, unfortunately. And so we're kind of finding that, and, we don't know exactly the cause. There's obviously other things that happen, pollution in the air, other genetic factors. family histories and things like that that can likely affect them. But definitely smoking is not the only thing. And so you can't only assume that someone who has lung cancer must have been a smoker.
Right. Yeah, that's so true. I mean, I'm learning how many different types of things can lie under the surface when it comes to your health. And, we also live in a major metropolitan area, so there's pollution against us, unfortunately, in New York. But doing this job and doing it for the time you have, I can't imagine it's easy. I imagine in many cases it can be rewarding. I would love to hear what you like most about your job and what you find the most challenging.
Sure. So, I mean, I think the patient interactions, like getting to know people that you take care of, like you, is a generally a big rewarding part of the job for sure. When you kind of you get to be with that person and take care of them for a very long period of time, hopefully. And so there's that connection. And then I can honestly say, at least within the type of cancers that I treat, for a lot of them, there's been a lot of progress. And so just in the time I've been doing it since I started, which is maybe a little less than 10 years, things have changed so much. So part of the thing that's gratifying is seeing like that change and seeing people do so much better. Even just when I started, I haven't been doing it that long. So, but just like, starting and saying, like, oh, I have so many more things I can do than I did, 10 years ago. And so that's obviously, that can be challenging too, because there's a lot to keep up with. And, I think probably one of the main challenges is trying to get the treatment specific for that person. So, there's drugs and there's things, but everybody's a little different. So trying to figure out what's the best treatment for that patient, using all the things that we know and the drugs that are approved and everything, but we have to tweak a few things or adjust things, or we have multiple choices, and what's the one that works for this person, or we think will work best for that person.
Yeah. Yeah. I mean, I can't imagine because every person, as I'm sure you see more than I do, but like every person from diagnosis to diagnosis, or even the same diagnosis, is totally different and may come with different symptoms, may have different reasons for it happening. So I can't imagine how you're navigating all that and personalizing it. And I know that you were able to personalize it a bit for me. So we'll talk a little bit about that in a bit. So, thymoma, when I heard that, my mind went back to like at some point in school, I remember learning about the thymoma and that it was a gland that was supposed to shrink over time as we got older. And that was like the only random, like weird fact that I ever remembered hearing about a thymoma. I even remember telling some of my nurse friends who have worked in hospitals and, have been in their careers for years now. They were like, I actually had to look that up and see what that was. So thymomas are pretty rare. I know we're here in New York and it's a major city, and maybe you get people from all over the world. I know Dr. Port, who may ultimately do my surgery if we get to that point, had said people come from all over the world to see him. So I imagine if the two of you are working together, you're probably seeing people well outside of New York. But how many thymoma cases, if you know off the top of your head, or can even average, have you seen in your career?
So it's actually, the thing about thymoma is that's different, and why Dr. Cook sees a ton more than I have. So to answer your question, I don't see a ton because a lot of them are treated just with surgery. And so he sees a bunch because a lot of times he's the surgeon and he'll take them out, and that's it. And there isn't a lot more that we do. Sometimes there's radiation. And so my job, as you know, is giving chemotherapies and other types of therapies that travel all around the body. And so, we often don't do that for a lot of myeloma if they can just be removed. And so that's kind of the primary treatment. So he sees a lot more. Yes, exactly. And then, but I'll see some patients like you, and that's usually the situation. It's like, well, he thinks like if I can shrink this down, I can get it out better. Well, after the surgery, it's like, I don't know if I got it all, and maybe some more treatment might help, especially if it had already spread to like the lining of the lung or something. Then he'll say a little bit more treatment might be beneficial. So those are the patients that I tend to send to.
Gotcha. Yeah. I mean, how many, so knowing that you're maybe not seeing all thymoma patients, but knowing that you're seeing some who need to get treatment, how many would you say you see on average per year?
Yeah. So, I mean, it's not that common, just like you said. So maybe one or two. Maybe.
Get out of here.
Yeah.
Wow. That blows my mind. I mean, so for people who have listened to past episodes, you've heard me talk about how rare this is. I didn't realize it was that rare, but
So again, it's not necessarily that it's rare in general, but for like oncologists and not the surgeons, it's not that common.
yeah. I mean, it amazes me. And I remember you saying to me when we first met, you were a bit surprised that I had never really had any difficulty breathing, any chest pain, any coughs, like nothing like that. I mean, I was a very active person. I still try to be, but just, in different ways now. Healthy, ate really well. I mean, as we came to find out, had some viruses in my viral load and had, some other things going on. Had some issues with fertility, which I know we talked very openly about in the beginning. But yeah, I mean, I don't know, blows my mind at how little to hear that you see on a yearly basis, because I think that was the hard thing for me to hear when I asked you about treatment. I mean, I'm sure you remember I was like digging my heels in the ground, didn't want to do it. I feel a certain way about, some of these medications because you hear that there are serious side effects, right? I mean, it's a serious drug and it travels all throughout your body. So I was pretty resistant to it, especially in the beginning. But I did have you check on my KI67 number, and that was very wildly high. So for people who have no idea what that is, which I'm sure is like everybody, can you explain what that is? And
So yeah, it's generally we use it as a marker in the cells to see how quickly they're dividing. So when they're higher, they tend cells and the cancer cells tend to be dividing and growing quickly, as opposed to a lower one where they're maybe more indolent and not dividing or growing very quickly.
yeah, do you remember the number of what my percentage was? I do.
Yeah, I don't remember the exact number, but I know it was on the higher side, which is why we were like, we really need to do something because it's growing quickly.
Yeah, it was unfortunately an 85%, which is crazy high. I mean, that totally blew my mind. We did sample that the tissue that we biopsied was actually from the lung lining. So it's interesting to think that, and I don't know if you think that maybe there could be a difference in how quickly that tissue was growing versus the main mass. I mean, the main mass is, or was, hopefully now it's much smaller, but
Right.
it was pretty large. So it really was kind of stopped me in my tracks when we got that information.
And it was like surprising because you were actually looking and doing pretty well for how big it was. So that was one of the things that I was pleasantly surprised, and I think it goes back to what you were saying about you were in good shape beforehand. So it's will take a lot to slow you down, and so you came in with such a big mass, but not with a ton of symptoms, which is what I would have expected.
Right. Yeah. Exactly. So the people that you do see, I'm so curious if there are any commonalities in the people you've seen over the last decade that have had thymomas. Maybe not.
Yeah. So again, I think you also have to kind of remember that I'm seeing like a select group of the thymomas, the ones that are already more advanced. Um, so they're all they tend to be a little on the younger side, I would say, compared to my lung cancer patients, which are much older. Um, but and they're pretty equal in terms of male or female. The typical places that it does go to when I end up seeing it is on the lining of the lung, and in other parts of the lung. But otherwise, they can be pretty different. I've had older men and younger women, and so it can be pretty disparate.
Okay. So kind of runs the gamut. I was interested to see if there was some kind of trend. I found a couple people, truthfully, through social media that have gotten thymomas. One was male, a little bit older, maybe in his late 40s, early 50s now. A couple were some girls, like relatively around my age, maybe give or take 3 or 4 years, some that had just had surgery, even with a larger mass, and some like me who had gone through treatment and also gone through surgery. But, of those three people, they all seem to be doing okay. So I'm holding on that that's going to be me too, because I have
Yes,
a very
yes.
strong mindset around this. I don't know if you remember me telling you, but I was like, okay, you can do whatever you want with your medication, and I'm going to be healing. I don't know. Do you remember me saying this?
Yes,
I was
I
like,
do.
I'm going to be healing this with my mind.
Yeah.
Yeah.
So, other patients that I have a time with are doing well. So I think I have no reason to think you're not going to do well.
Happy to hear that.
Yeah.
I guess outside of what we've already covered, was there anything else about my particular case that surprised you? And how confident did you feel to treat it?
I mean, I felt pretty confident to treat it. I felt that we could do something, and well, again, the ultimate goal was to get it out. And so, my job really was to try to make that as easy as possible for the surgeon. So I did feel confident that we could treat it, and after getting to know you, I felt like you could tolerate the treatments because you're, like you said before, you're in good shape. A lot of the patients unfortunately, that I see have a lot of other medical problems that I have, like going back to has to be sort of tailored to each person because they come with their own medical problems and sort of treat them outside of what they already have, both medically and, psychologically and socially and things like that. So you kind of have to tailor your treatment.
Well, I tell you, if this had happened to me like 5 or 10 years ago, you'd probably see me, and I'm not saying this lightly by any means, but you'd probably see me struggling a lot more mentally. So, yeah, I mean, my heart goes out to all those people, everybody that I see on the floor on a weekly basis that just, are not feeling well or, are just not in a good headspace. I just want to give them a hug and be like, it's going to be okay. But, nobody knows what's going to happen tomorrow. Yeah. So I tell everyone, my mindset is I could get hit by a bus tomorrow. So
Exactly.
why not just enjoy life?
Right. Exactly.
So I want to give you a little bit of recognition because right around the same time, or actually maybe a little bit before you and I met for the first time, I had started working with a naturopathic oncologist, Dr. Lori Bouchard. And I know I told you a bit about her and some of the things we were doing with the fasting and the keto. And, I think you acknowledged it. I don't know that you necessarily had a strong opinion around it, which I totally respect. And that's fine. I mean, you're in your lane, she's in her lane. But I love the fact that I have a holistic team on both sides and I'm trying to marry the best of both worlds. And you were willing to talk with Dr. Lori. So I don't know how much you recollect from that conversation, but after that conversation, there's tons of blood work that they look at on a monthly basis, which you see because you're willing to order that for me, which is a huge help. Otherwise, it'd be costing me so much money out of my pocket. So we're able to do that. And I thank you for that because we're able to run that through insurance. So that makes my life a little bit easier from that perspective. But they look at things, I think, that we don't necessarily look at on a weekly basis. So it's interesting for me to see how much they're able to analyze from that. But if you can remember that conversation with Lori, I don't actually know what you talked about aside from the fact that you're both seeing me. What was that conversation like? And what did she share with you or vice versa? And how did you feel about that?
Sure. So, I mean, I think it was a good conversation in that similar, like what I said with the surgeon, Dr. Port, like my goal was to kind of shrink it down and help you get to the surgery. So she sort of said, like, her goal was to help do whatever she thought she could to help the treatment work better, or what she wasn't sort of like, I'm going to do this, so don't do anything because I'm going to do it myself. It's just like, I'll see what I can do and what we can get that might enhance the treatment or just make you feel better or have you have less side effects or something that's so that you tolerate the treatment. Obviously, as you know, if you're feeling sick from side effects, you're not going to do the treatment. And so, she was very much of the like, what can I do to help you get through the treatment? Understanding that she's like, I'm not going to tell her what treatment to do, but maybe what can I do to get through it and maybe help it in any way. So I thought that was really good and a good working relationship.
Yeah, and I appreciated that. So after you had that conversation, she actually said on one of the weekly calls that I have with her and some other patients, she's like, Jamie really has the gold star oncologist because you are kind and, you've treated me like a human being and you had a willingness to talk to her and at least an open mind to hear me out, whether or not you said, okay, Jamie, you're crazy after I left the room. I will never know and probably don't need to, but you were willing to consider how I was going about this. And that really meant a lot to me. So I again want to thank you for that. And I want to let you know that that's how you're referred to on the naturopathic side of things, is like the gold star oncologist. So good job.
That's good to know. Like I said, I think, sometimes you do have to focus on the specific person, and what their beliefs are and what they're thinking, and you work with them.
Definitely. Yeah. So there very well are people who just don't know about how, and I, I'm like N of one, but I also talk to people on a weekly basis who are working with Dr. Lori for different reasons and different diagnoses. But I'm hearing and seeing these people go through treatment or go through surgery and just feel good. It's a community of people who are going about it with their best effort. So that's where I feel like it has really helped me, for the most part, rebound pretty quickly with these treatments. So I love the fact that I can marry both. So that being said, How has it been for you to work with somebody like me? Like, how often do you get people coming into your office saying, I'm fasting, I'm doing a keto diet, I'm paying attention to what I'm eating, I'm healing this with my mind?
I think nowadays people are, looking into other things to help them get through their treatments, and there's obviously a lot out there. And I think, trying to also just make sure that you're not doing anything that could be harming yourself while you go through the treatment is part of my job as well. We also very fortunately have at our institution an integrative medicine program. So a lot of times when patients have a lot of those questions, and aren't able to get the answers on their own, I'll refer them there. Honestly, may not have the answer. I can, if they come to me with something like, I want to take this, I can kind of look into it and see and make sure it's okay. But just a very general thing, I won't pretend to be that super knowledgeable about all of these things. And again, some people can do a lot of the research and have their own natural path separately, but a lot of them don't. And if they look for guidance, I try to send them to someone who has qualifications that can help them.
That's awesome. I didn't actually know that. So, I mean, I guess I came in with my
own. Yeah, I was going to say you didn't really need that. Otherwise, that would have been my plan. People let me refer you, but you already came with it. So.
Is that somebody, I don't know if you said that and I just didn't hear it. Is that somebody within New York Presbyterian?
Yeah. Yes.
Okay. Well,
yeah,
that's good. I think to your point, there's so much information out there now that people can go look and take it upon themselves. My husband, Nick, was actually the one who found this whole approach that we're taking. And I was grateful for that because it's definitely how I operate and what I value. But to get a diagnosis like this was so overwhelming. And I just was like a deer in the headlights. So it was helpful to have that put in front of me. And then I really do think, I did end up going to Memorial Sloan Kettering. I didn't talk to their oncology team, but I did talk to their surgery team. And they had actually told me that I was in better suited hands with Dr. Port at New York Presbyterian and the way that they were going to handle it based on the complexities of my case. So I have felt very comfortable both with you
Good.
and, with him and the limited interactions that we've had so far. So I think you're doing a great job.
Thank you.
Yeah.
Thank you.
Until you hear otherwise, you're doing a great job. So I do want to, because you brought it up, especially in the beginning, because of all the work that I had been doing with Dr. Lori's team and how truly hesitant I was to do, so hard for me to say the two C words, chemotherapy and cancer. I don't like to say it about myself. You're going to hear healing journey and you're going to hear tumor, and that's about it. But in terms of going through chemo, that was a really hard pill for me to swallow. And no, that was actually something I did intravenously. It was not a pill. But we did end up doing the DATAR test. So I remember your reaction to it, but I would love to hear it from you because this was a test where they took my blood. They actually shipped it overseas to the UK. They took, I think, 3 large tubes of it and they tested for different things. They tested, effectiveness of chemotherapy, all these different types of chemos on my blood. And then they tested off-label drugs. And then they also tested non-pharmaceutical drugs as well. So we got those results. I was hoping to have them before I went through treatment the first time in the winter, and something happened with my blood being shipped overseas, and it was a really traumatic day for me. So we didn't have that. So we went with kind of the standard of care guidance with the three drugs we used. And then the second time around, we ended up using that to guide the treatment. So tell me your thoughts on that DATAR test and how you felt about it.
So, there are a lot of tests out there that are supposed to help you make decisions and things like that. With this test in the blood, I think one of the things that to remember is they basically are trying to find the cancer cells in your blood and test different things on them. But that's just the cells of the cancer, and you are a whole organism. And so just because something works on just those cells doesn't mean it's going to work on you as a person, because there's a whole other thing. The cells are in other, they're in a environment, and there are other things in the environment, and there's, yourself, and, nothing about that test factors in what you're eating and whether you're eating well or you're fasting. None of that factors in. So, it's an interesting test, and we do similar things in the laboratory, and we look at cancer cells and we test different things on them. But rarely do we use that information alone to say you should get this treatment. It's a good, helpful kind of thing, and it's good information. But I was hesitant just to say, like, well, we're going to do whatever this does, because most of the other treatments that we kind of were considering at least have been done on people before, and patients, and had some sort of data for how well they work in myeloma.
Yeah, and I mean that's all fair, right? That's completely fair, and I hear that. I mean, our body is definitely a very intricate system, and there's a lot going on. So certainly, when I heard you share that with me the first time, I was like, but I was also like, okay, well, take it as it is, because it is the only personal information to me and my cells that I had. And after the first time and like not feeling so great with the meds that we tried, I'm like, okay, well, at least now we have something to back up this choice. So, and correct me if I'm wrong, but the two drugs that were the highest on that chemo test that we ended up using, those have been used to treat thymomas in the past,
Yes,
right?
they have. So they're not generally always the first choice, but they're one of the choices that happen in thymomas, particularly aggressive.
Gotcha. Okay. Yeah, I mean, I also have to say, again, appreciate your willingness to work with me, because I'm over here like, yes, of course, I want to shrink this tumor, make it invisible, make it disappear, make surgery not even have to be a possibility. Who knows? Anything is possible, right? Literally anything is possible. I'm not God, you're not God. We don't know. We're just doing our best. But the way you to work with me the second time around was to do more of a low dose. I know we lowered our doses last time, but truly do more of like a low dose chemo protocol. And in doing that, I ended up coming to see you, and you were probably so excited to see me every week for 8 weeks.
Totally fine. I loved it.
Was not easy, but I will say I'm happy we chose to do it that way, because for the most part, aside from like this last week where, it's just hit me a little bit harder, I have been able to bounce back to be like my normal self within 24 hours. I mean, a lot of the side effects were minimized. So I was really happy about that. And I remember asking you, so I'd love to hear it from you, have you done this way before? And do you see a difference in doing like a higher dose versus pacing it out like this?
So usually, we do the lower doses, and depending on the person, some people are just very sensitive, and it's hard for them to tolerate. We usually try, give them the full dose, but if we know that they're not going to tolerate it, or they don't tolerate it well, then we often have to go down on the dose, and try to maybe fraction it out, and try to get it in lower, or different ways of kind of doing it. So, you're not the first person that done this for or had to do it for. Like I said, it really depends on the person, how that well they can tolerate the treatment.
Makes sense. I mean, I know you had mentioned to me that you often end up doing it that way for maybe people who are a little bit older who might not be able to handle something higher. Have you done it with younger people as well?
Again, if they usually not, but generally if I know if they have something where they're just not able to tolerate the treatment.
Gotcha. Yeah. I mean,
Side effects.
So far it's been an easier road for me.
Yeah.
So, maybe I'm just unique, or maybe I'm like an 85-year-old and like a 36-year-old body. Okay. So something else, this is kind of like throwing us in a slightly different direction, but when we got the DATAR test back, and I would actually love to hear you explain, if you can, the VEGF pathway, a VEGF inhibitor, because I have an understanding of it. And when we got the DATAR test back, from my understanding, that was showing, I mean, we've run VEGF tests in the blood. I know that is typically something that comes up very high. So my understanding of VEGF, that is the tumor's ability to grow its own blood vessels and basically take in its own food supply or fuel supply, if you will. So that's been scary to see that be so high, of course. So that's like an angiogenesis marker. And on the DATAR test, it clearly showed that was a way that this tumor was being fueled. But it also recommended a VEGF inhibitor as something to try to treat. So can you explain, if I did not do a good job, or just share a little bit more detail about a VEGF marker and the way a VEGF inhibitor would work?
Sure. So, I mean, you're right in the sense that VEGF is a protein. It's that is kind of signals cells that help them grow their own blood vessels, angiogenesis. So, a lot of cells have them or secrete this to help grow blood vessels. And then the inhibitors usually block the signaling that they do in some way. They inhibit the ability of the cancer environment to grow blood vessels to feed itself so there's many of them. It's actually one of the ways that we treat different cancers, including lung cancers and thymomas as well. There's VEGF inhibitors or drugs that have this activity of inhibiting VEGF along with others that we use in thymomas. They're generally oral therapies, so they're usually pills that can be used.
Are they effective?
They can be, yeah, they're effective. They're, again, not usually the first things that we try because they may not always be that effective. Unless, it's easy to think like, well, they're pills, they should be a lot easier, but they do have their own side effects. So, it's not that they are like completely harmless. So sometimes they can be really tough to take, and you end up reducing the dose just like, with the chemotherapy in the same way. But they're definitely used for different types of cancers, including thyroid.
Yeah. Thank you. I mean, I didn't realize that was a protein, so I just learned something. So thank you for that. When I picture that in my head, I guess I'm more of a visual learner. I picture, this tumor with the lights on, and then I picture the VEGF inhibitor kind of turning all the lights off, so to speak. So like closing all the circuits, and then there's a blackout, and then, the tumor kind of dies off. So to me, I was like, I know I was pushing you a little bit. I was like, why don't we try this? It seemed like a no-brainer because that number was so high. So I don't know if you can speak to this, but can you explain why, as you said, like it's not the first line of defense? So we actually tried to do it and we got denied from insurance to kind of like skip a step, I guess, so to speak. So can you speak to that?
Yeah, I think a lot of it goes by, we usually pick these treatments about one, how effective they are and how much they've been used. So, the studies with these are a little smaller. Most of them are with patients who've tried chemotherapy first. So, it sounds like they're slam dunk, it's going to work, but they don't always work as well as we hope or think. And not that they're not an option. And for some people, they do work really well. And so sometimes the trick is finding who are the people that it's going to work really well versus just giving it to everybody, when maybe a lot of those people, it won't work so well for.
Yeah. Are there any commonalities with the people that it has worked for?
Not specific that I know of. The other thing I would say also is, one of the side effects they can have is sometimes wound healing problems. So, like, let's say you're going for surgery, and you may not want to have that because then after the surgery, you may not heal up there.
Yeah.
Yeah.
That's a whole nother.
But I know we're doing research to try to find out, like, who are the people that are really going to respond so that we can target those people.
Saying when you get that, you share.
Sure, of course.
Maybe we won't need that information at that point.
Yeah, we won't.
Still interesting. In the very beginning, I came in with a list of questions and I asked you like what the success rate was of the chemotherapy. And you had said to me anywhere from, I believe, 20 to 50% effective. And that, like, I was looking for a really hard sell. And I was just like, I literally just like saw black and it was like, don't do it, don't do it. Because all I heard was it's 50 to 80% chance that it may not be effective. And so as somebody who really didn't want to put that in my system, and I appreciated you saying this, but I was like, well, then find something else. You were like, I wish I had something else to give you. And so, we tried and we kind of tried it in, again, my own Jamie way. So we saw what we saw with the results. And then here we are again, trying it differently, trying the protocol differently, going a little bit more frequently and changing the medication. So time will tell how well this is all working. So if you're listening, melt away.
Yeah. And sometimes that's what it is. It's a little bit of, we don't know exactly for each individual person what's the best one. So sometimes it's a little bit of trying one thing or another thing, and which one will work.
I mean, it's tough because I end up feeling like a lab rat.
I know. It's difficult.
And I'm sure maybe you feel that way a little bit too. It's like this is science, right? Science is always changing. The literature is always changing, which is a great thing because I think advancements in technology and advancements in medicine can really be helpful to us. But with something like a thymoma where there's not a lot of research studies out there, from what I've seen, it's like, well, I don't know, what the hell do we do? I was like, okay, this is an opportunity for me, whether or not you want to hear this, for me to kind of take the reins a bit, gather all the information, talk to all my people, develop my entire team, and make this work for me. So, I have you helping me like choose the medication and paying attention to the side effects and seeing how that's going. And you're helping me get the scans and monitoring the size. And then I do have Dr. Lori and her team helping me, I think, like bounce back as quickly as possible and, feel good, and looking at maybe some other factors that are kind of helping me as a whole person. So it's like I've got my whole team, and I did feel like there was no right answer and there was no totally wrong answer, which kind of, I think that's hard for probably most people when they get a diagnosis. It's like they just want to be told what to do.
Right.
I don't like to be told what to do. If you can't.
I'm well aware.
So what percentage, at least in your experience or with what you do know about the thymomas that are out there, cases in the world, what percentage of people see a reoccurrence with thymoma after either chemo, or if you're working with the people who are going through treatment and then having it removed, do you see those have a reoccurrence?
So again, it really varies because it depends on what else you're doing. It's generally higher recurrence if all you can do is the chemotherapy, because we don't know that it's going to be curative, or say usually that, oh, this is by itself going to cure you. But then it's a lot lower if it's someone who gets surgery, and then it also depends on how how well the surgery goes, and also radiation is involved. So it really depends. It's really hard to one number. It depends on that specific situation.
Right. Can you maybe answer this one for me? And I'm not like holding you to this answer by any means, but for people similar to me who have had it move into the lung lining, do you typically see a reoccurrence?
You typically do, because it's kind of knows to travel. That's traveled from one place to the other. But oftentimes you have a large period of time before that happens. And so, it doesn't necessarily happen right away. And so I think a lot of times thymomas is maybe sometimes different than other types of tumors is you can just kind of go back in and say, well, it occurred here, so we go back and take that out. Because it's been many years since the last time it was an issue. So we'll go back in and do it.
Yeah. And typically, or maybe always, the thymus gland is also getting taken with surgery.
Yeah.
So
Yeah.
Interesting. Yeah, I know Dr. Port had mentioned sometimes it's just a freak thing when we go in to do the surgery and we take the thymus gland out and we notice, like I mentioned at the beginning, like that weird fact that I remember from school that it's supposed to shrink. Sometimes we notice that it hasn't shrunk in people who get the tumor. So I'll be very interested to see what happens if and when we get to that point. Do you feel like there's anything that I maybe neglected to ask that could be relevant to this conversation?
That I can think of. I think it's important, like we talked about, to focus on each individual person and kind of like get their treatment that will work best for both their tumor and that person. And I think those in the relationship you have with your physician is obviously very important too. Like you alluded to, you have to kind of feel comfortable with it.
Yeah, for sure. I mean, sometimes I maybe feel a little bit too comfortable, but again, I think me as somebody who grew up very sensitive and like, especially when we're talking about me or talking about something serious, like that could elicit tears or like a nervous breakdown at any given moment. I need to lighten the mood and like break the ice and make us laugh because it just brings out the humanness in the entire team where it can feel super daunting and intimidating. So that's kind of where I come from with my personality. What would you say is the most frustrating part of your job?
I mean, obviously, having bad outcomes or patients don't do well, that's obviously very frustrating. I think sometimes people also, because there is a lot of this, a lot of feelings about particularly chemotherapy and what can go wrong, and how sick you can become, which is all valid because people do get very sick from it. But usually, a lot of times, what I tell patients is like, I'm going to give you all these possible side effects, and they could happen. But what I know is happening to you is that you have myeloma or you have something like that's not an if right now. It's turning. Maybe you'll get sick of chemo. Hopefully you won't, but for sure you have myeloma. And so generally the tumor is worse than the what's going to happen. Well, maybe with the treatment. So trying to also get that across that we'll be here for you if you have a side effect. We will help you. We won't push it and be like, I know you're super sick, but you're getting it anyway. It's a conversation, but understanding that it can be beneficial, and you may not get very sick if we make some adjustments.
Yeah, I mean, it's so wild to me because I remember learning that these are typically resected, which is like the typical line of treatment, as you said, so surgery and not necessarily treatment needed with an oncologist. So like my mind was just blown because I'm like, yeah, I don't have any symptoms. Like the only thing was my eye flare up, which I really have to be grateful for as much as it sucks. It was like the one thing that led me to discover this, but I had been living my life active, healthy, like doing all the things. Everyone's like, how the hell did this happen to you? Because you're the healthiest person I know. I mean, it just goes to show you, I think there's so many different things that can cause this type of situation. So for me, it was really hard to hear like, yeah, you're going to take these drugs and, you might feel a little crappy. You're going to have side effects. And it's like, well, even to hear you say that, it's like, I felt totally fine before all of this. So like,
and
it's hard to wrap your mind around.
And it's harder when you feel really good. It's really good. A lot easier when you feel bad and I'm like, I'm going to give you this and it may have side effects, but if it shrinks, you'll feel so much better. That's a lot easier than when, like I already feel good. So I totally understand.
Yeah. Yeah. It's so, hasn't been easy to show up the last 8 weeks, but we did.
You did.
So we'll see. Finger things looking good. So what made you say yes to doing this podcast? 'Cause I'm not going to lie. I came in and I was like, okay, I need to ask him before these 8 weeks are up while we're still seeing each other face to face, because I thought you were going to say no.
No.
Like either I can't do that just from like, coming from your chair as an oncologist at the New York Presbyterian, at the New York Presbyterian, I guess I just New York Presbyterian Hospital, because there are a few. I really felt ballsy asking you to do this with me. So what made you say yes?
I think a lot of it was, like you said, we've had a long relationship and we've gotten to know each other, and thought it was good to discuss and really good important points to talk about and get information out there. So I didn't really, I wasn't selling anything or talking anything or speaking specifically for the institution I work for. It was just myself, and so I'm not really representing the hospital here. Yeah. And yeah, I think it was just you.
Yeah. Well, thank you. I mean, I had put it out there the day that I asked you and you said yes. And I'm trying to remember, I don't think Nick was in the room with me. So my husband comes every week. God bless him. I don't think he was in the room with me when I asked you. And I came out and I was like, we got a date. I didn't let you leave, or I didn't let myself leave your room, I should say. You could have gone if you wanted without putting a date on the calendar, which just out of respect of your time is why I still wanted to show up like this today. And I also think, and I'll send you my podcast so you can maybe listen to some of the other episodes.
Absolutely.
But I think it's important, at least from the way I've been sharing this journey, to be transparent. I tend to be a pretty positive person. So like, sometimes you see me at my lowest, but like I still try to just, okay, we're here, we're going to move through it. The nurses have all been really great for the most part. And so that's helpful to make it a little bit easier too. Everyone's like, oh my God, you're so positive all the time. It's like, well, I'm not positive all the time. It's impossible. I'm not a robot. I'm a human. So for you to say yes to this, for me to be able to share this side of things, I think is going to be pretty unique. And so I actually put something out there to like, not that I have a huge social media following. Listen, I've got like maybe 4,000 followers, but I'm hoping for that to grow, because what I want to do on this podcast is bring experts in like you. I've done some solo podcasts myself. I've actually had a conversation and I want to have more with Nick, just from like the spouse and support side. And then I've met, as I mentioned to you, like outside of people who have thymic, so many other, lots of young, unfortunately, people who have gone through their own diagnosis or are actively going through it and are willing to share their story. And so I think having a platform like this, especially with the way I'm going about it, which is a little unique, as you know, is important to me to share so that people can learn from it. So I think when I put it out there that I was like, you know what? My oncologist agreed to do a podcast episode. People were like, wow, no way. Like, this is awesome. I can't wait to hear it. So I think hopefully there's a lot of good information that we share, and you can clearly see the relationship that you and I have, which
Absolutely.
usually friendly, unless there's a point in time where you need to be stern. And, I respect that too. But again, I just want to thank you for your time. So honor this, even though I was feeling this way, I think it's important to be transparent. So my last question, because I don't know if I told you this, but my podcast is called The Forward Think Tank. And that is because prior to me being Jamie Mazza, which is how you've always known me, my maiden name is actually Forward. So I've always been pretty forward personality, kind of just, maybe that was because I embodied, but, what keeps you moving forward in life and, maybe also in your career?
I think definitely in the career, it's one of the progress that gets made. Like I said, maybe at the time I got into the career, but there's just so much very quickly, and I tell my patients, when I started, I would say one thing and your prognosis was one, and now it's completely different. I almost, even for some of my more advanced patients, like I used to give them like, oh, I think probably you may have this much time or something. And now I literally say, I don't know how much time you have, because there's so much out there. And some people just are responding amazingly to what's out there. And so I won't tell you how much time you have, even if you ask me. I don't know. So I think that really makes it, and that changed, with time. You didn't, like I said, I haven't been doing this that long, but that rapid really keeps me going forward.
Yeah. I mean, just to touch on that, there have been times where I've thought to myself, like, I guess when you hear the big C, as I call it, like, people always give you a timeline. And we never had to have this conversation. So I'm so glad that you never said that to me, because I would have been like, blah, 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 blah.
Right.
Like I said to you before, like, I'm not God, you're not God, we don't know. So I actually really respect that. And I'm sure maybe there are people who are scared and want to hear that so they can plan, their bucket list. But like, regardless, like, nobody can tell you. To your point, like, you don't know how people are going to respond. So if you're feeling well enough, like, and you're going through something, this is your time to hear this from the two of us. Like, go out and do something you enjoy now.
Absolutely.
Life is happening now.
Yes. Definitely take advantage of it every day.
Yeah. Any closing thoughts?
I just thank you so much for inviting me. It's been a lot of fun.
Thank you. Yeah, I will definitely send it to you so you can show
Thanks.
all the nurses on the floor and all your doctor friends. I mean, they're going to think I'm a total nut job. I told my sister, I said, listen, I can either, which we'll see, but I kind of like this. I could have either done just the audio, and I'm not sure if it actually would have still captured our video, or I can show up like.
I think you made the right choice.
Thank you. It's, a little bit of a disguise, but I love Halloween and I love dress up, and it's also pink. So
exactly. Breast cancer awareness, right?
All the things. So thank you again. I won't keep you because it is 6:01.
Yeah, perfect. See you right on.
And I am probably the only thing standing in between you and your weekend. So
That's okay.
Enjoy your weekend. Thank you again.
Of course.
And I will talk to you soon.
See you soon.
Thank you.